My name is Michael Battelle, and I'm the president and founder of the Fatty Liver Alliance. We raise awareness about the risks, causes, and complications of fatty liver disease and help those already diagnosed with NAFLD and NASH by advocating for access to approved treatments and care. I have known our guest today for close to 30 years, and I'm thrilled to have him back to share his experience and insights in the world of non-invasive liver testing. Dr. Robert Gish is a gastroenterologist and a professor of medicine at Loma Linda University, an adjunct professor of medicine at the University of Nevada School of Medicine in Las Vegas, clinical professor at the University of Nevada Reno School of Medicine, and a clinical professor at the University of California Skaggs School of Pharmacy and Pharmaceutical Sciences. He's based in San Diego, California, and he sees patients throughout California and Nevada. Dr. Gish, estimates of fatty liver disease at 25 all the way up to 40% means that not everyone with fatty liver disease will be able to have a biopsy. Probably they shouldn't anyway. And they're going to have to be assessed for advanced liver disease. So there's probably many non-invasive options out there for patients. Could you start by sharing with us what is currently available and how they differ from each other?
Be glad to, and thanks very much for having me. This is a great service to the community. Everybody needs information for support, and this is fantastic. So, as you said, liver biopsies really now are used for clinical trials, rarely used in clinical practice because of the benefit and risks are not really out of proportion. In other words, there is a risk of the biopsy, and getting information out of the biopsy is limited because of the small size. So when we talk about non-invasive testing, we want to be able to take a look at the whole liver indirectly or sometimes directly without a biopsy. So let's break this down into what type of tests that we have. We have blood tests and we have imaging tests. We're going to start with the blood tests now, if that's okay, Michael.
Sure.
Blood tests are broken into two groups. We have the ones that are basically free, and you go online with certain calculators, and the three favorite that I have is called the NAFLD score, APRI, and FIB4. And the information you need for those calculators are off a chemistry panel, age, body mass index, people have diabetes, just some very simple questions. And each one's slightly different. I'd say the FIB4 is probably the most accurate, but it has problems when people get over age 65 where it can overestimate the liver damage. And what these tests are doing are staging the fibrosis. So I'm going to get back to talking about fat in the liver in a little bit later, but right now it's about staging. Do we have someone have cirrhosis? Are they near cirrhosis? What's their trajectory? How fast or how slow is the disease progressing? So we talked about free blood tests. There are commercial tests that cost money. FibroSure and FibroTest have been around for 20 some years, originally used for hepatitis C back when we were working together, Michael, in the C world. And then finally, we have some new commercial assays. The one that's probably the most interesting and important right now is the ELF, Enhanced Liver Fibrosis Score, made by Siemens. I have not ordered this test yet, but apparently it's available through Quest and LabCorp. I'm going to get back to the non-invasive tests, a couple hacks, so to speak, in a few moments, but now I'm going to move on and talk about imaging. Is that okay, Michael?
Yeah, of course. No, it makes sense perfectly.
All right. So imaging, we take a look at every patient with fatty liver. We take a look at their liver with ultrasound. And the ultrasound will say fat, yes or no. But it takes, depending on the radiologist who's reading it, you need to have at least an increase of 5% of fat in the liver. But ultrasounds really start picking up fat as a signal when it's over 20%. So the ultrasound's not that sensitive. But when you order an ultrasound, you should always be getting a spleen size and portal vein diameter because those help you stage the patient. The spleen should be under 12 centimeters and the portal vein should be under 12 millimeters. I call that the 12-12 rule. And if the spleen is big, the portal vein is big, or both, the patient has portal hypertension. They have advanced fibrosis or F4. And that ultrasound and getting all those measurements is inexpensive. It's not free. The ultrasounds cost between $200 and $400. There's no radiation, there's no IVs, there's no loud machines. So an ultrasound is essential. Now, in that ultrasound world, we have what's called elastography. EchoSense is the most famous with their FibroScan device that delivers stiffness through a special type of sound pulse that goes out. Very narrow column, though. It doesn't sample a lot of tissue. There's new competitors in this space. One of those is by a company called Sonic Insights with a test called VelaCure. And it's able to sample a relatively large amount of the liver under an ultrasound guidance. Very nice. The other competitors are the ultrasound companies that are in this space. We have Siemens, we have GE, and I'm leaving one other one off, but there's a third company in this space that has elastography built into their machine. But the problem is they don't publish very much. We're not really that sure of the accuracy with these ultrasound-based elastographies. There's a new company in this space. What's a new company called Hologic, which acquired a French company called Supersonic, and they have a machine called the Explorer, and that has very high resolution ultrasound, beautiful pictures. Also can measure elastography using that. And they have a couple of things. We have point shear wave, 2D shear wave, 3D shear wave, something called ARFI, acoustic radial force, assessment or measurement, ARFI, imaging. So ARFI is the other one that is used in this space. EchoSense by far has the most publications, although it does have its challenges. It's not perfect. So finally, in that imaging world is the magnetic resonance scan, MRI. MR can measure fat through something called PDFF, also on top of the stiffness measurement, elastography. Quite expensive, even though a lot of people consider it the platinum standard. I'm going to say gold standard because it really does take an expert to read it correctly or to set up the imaging correctly. I'm going to get down a little bit of a path, Michael, which has to do with assessing how much fat. I just mentioned an MRI measures fat with a PDFF. These other ultrasound machines can do a calculation called an attenuation parameter, CAP score or CAP equivalent, and that tells you how much fat is in the liver. Finally, very exciting, is a company called Perspectum, which has a device, a liver scan that is called the liver multiscan, and it does something called a corrected T1 that combines inflammation and fibrosis. Very useful in certain settings. Also, they measure fat and they measure iron. All this through an MR machine without getting a biopsy. So this is incredible news, Michael. We can assess a huge amount of the liver or all of the liver with these non-invasive tests. And I want to come back to those free tests just to completely close the loop. When you're looking at a CBC, look at the platelet count in all of your liver patients. Platelets over 170,000 is F2, F3. Between 100 and 170,000, it's F3, fibrosis 3, bridging fibrosis. Under 100,000, it's cirrhosis, F4, fibrosis level 4. And that's free. Just look at the platelet count, and you can also look at the AST-ALT ratio. The AST is higher than the ALT. It's very likely to be cirrhosis. So a lot of things we can do without a biopsy. I think even in clinical trials and drug development for fatty liver biopsy will eventually go by the wayside. But the fatty liver community, the leaders in this community, who are incredible, by the way, they need to convince the FDA consistently with very good messaging that we can get rid of the biopsy and talk about looking at the whole liver. And that's my long spiel, and we can break that down, Michael, but that's the big view.
Yeah, no, you did a great job, and there's a lot of information. So do you think that there's ever going to be a consensus about which one should be used, or do you think it'll be like an open market and people will choose whichever they're able to get or whichever is better for a particular patient?
There's a lot of work being done to combine these calculators into different types of scores. So you can, take one that's, free, and then you take one that you pay for, and then you take one that you image. And I think every provider should be looking at least at 3 tests in every patient, and then combining those tests through not artificial intelligence, but our real intelligence, and making a decision about that patient's F score. So yes, it's going to take, I think, 3 tests to be reasonably accurate.
It did seem like that at ASLD this year, that it was shared to be a combination approach really for the best assessment. I was curious too, just before we leave, in your practice, because as I mentioned in the opening, you see so many patients in the Southern California area. What do you do?
So I'm sitting in a federal clinic right now in San Diego called La Maestra. We have about 42,000 patients in this
Wow.
practice. And 3 times a month, I'm here for half a day, and we see 20 patients. And half of those patients have fatty liver, sometimes 70% in one clinic. And I do all the above. I have APRI, FIB4, NAFLD, ultrasound, fibroscan. And again, I look at the platelets, I look at the AST to ALT ratio, and I examine the patient. It really helps. Talk to the patient face to face, put your hands on, and then put everything together.
Okay, I'm sure that they appreciate not having a needle biopsy. So that's a great step forward, right? Regardless of the test that's being used at the moment.
We convince our patients to have a liver biopsy when they're in a clinical trial because I describe it to the patient as icing on the cake. I do that biopsy. I can look for other things in the tissue, such as iron, autoimmune. And also, I put that into the equation about combining all the tests. So we usually can convince people to get a biopsy once they're interested in research.
So you're over delivering, under promising, or one of the two. It's like
We try our best, under promise. You got it.
Thank you so much. As always, very informative. I know people really want to learn about this. Is a really important area with new information coming all the time. Thanks very much, and we'll talk again.
Thanks. Talk to you soon. Stay in touch.